Hush, the hush falls upon the room. You're all very welcome. I'm Michael Brown, one of the professors, and I'm the deputy head of school. Professor Kendra Crozier sent her apologies a little bit poorly, so you've got me as the follow-up act, but I will do my best. So you're very welcome, everybody, to this professorial address for Professor Ian Walsh, who's going to give us a walkthrough of urological issues, I think, is what we're going to be doing, which I've been told not to tell any urological jokes, so I'll do my best, but I can't promise anything. So I need to welcome Ian's wife, Helen, son Callum, wife Neve. We then have Emma, his daughter, and her husband Adam. We have John that's not here, and your brother Charlie has to be mentioned as well. So just a few housekeeping things. There's no fire alarm planned, so if they do go off, we did have a test this morning at 8:30, so everything was okay then. Leave the building with the nearest exit. We meet outside of the main building and do not enter the building until you're told to do so by an official. So that is all that I have to say, other than to hand over to Ian, and we look forward to hearing all about your interesting urological focus. So thank you very much, Ian. Or you can use, I can use that, yeah.
Thank you very much. Full disclosure, this is the most nervous I've been in my entire life. It's the strangest audience I've had in front of me. I'll keep it brief. No, I'm not going to keep you to the hour though, as it was advertised, because I just wouldn't do that to anybody. Not used to speaking in public, and I don't really like the limelight that much, as a lot of you will know. So this is all a bit odd for me. So I'm going to give you a little bit of a background to where I came from. A lot of you will know all about this, but also chat a wee bit about what sort of directions I travelled in through my journeys. If we can get the thing to work. Just bear with me. As I always say in these things, what could possibly go wrong, you know? Come on again. That's all right. I'll just use the arrows. That's grand. The arrows aren't working either. I'm definitely not nervous now at all. Just the There we go. So you see what's coming up, family, don't you?
It's working out, did I do? It's working out.
That's great. Okay. Thank you. So yeah, born to Kathleen and Jimmy. Jimmy was profoundly Scottish, and Kathleen was profoundly Irish, but wouldn't let on. She always used to say that she came from, a lot of her family came from the west of Ireland, where I live half the time now, and she always used to say, because her family came from the UK, so she claimed, or were part of the Raj, so she claimed that she was a royalist but not a loyalist, which was quite clever at the time, but when you've heard it for about the thousandth time, it gets a bit tiresome, you know. So where I was brought up was here. That's in Queen Victoria Gardens, and I think anybody in the room will agree it's not exactly salubrious. A rough enough area. The bit that was sort of pixelated out there said "Tags out." I was born and reared in this laboratory up here. That's our wee flat that was there at Queen Victoria Gardens, flat 23. And inside that, I was known as Son or Ian or Love or Wee Fella or whatever. And outside, I was known as Fenian Head, and would often have masonry thrown in my general direction, but often more specifically at my head, which was at that stage covered in lustrous black hair. Now no longer, courtesy of testosterone. That's the urological reference. This is my life now. It's moved on. This is my entire world. My kids, Emma, John, and Callum, and I love them dearly. And I'll mention them again later on, just for a bit of a laugh. But also Jimmy and Ollie, and of course, the other two, the big one there is Coco, and the smaller one is Phoebe. So my education started off at Edmund Rice Christian Brothers, where I was educated and exposed to profound violence by the Christian Brothers. And then I moved across the road to St. Malachy's, where I was educated and subjected to profound violence by the priests. All joking aside, the education I got in both those places was second to none. My boys both went to St. Malachy's. I don't know if they'll agree or not, but certainly the education I got there was stepped in tradition, but it was rich, and some of the stuff I learned there stuck with me to this day. I then came to here, to Queen's, where I studied at the Medical Biology Centre, as it was then in the middle, and is now. And I came back to Queen's later on, but I'll touch on that. And again, my years at medical school, and some of you that are in the audience were with me there. And if you can remember any of it, that would be great. I'm patchy. I trained in a variety of places, Northern Ireland, of course, but also did my houseman's year in Liverpool, and then went to South Manchester, came back to Northern Ireland, and then worked in a variety of places. I did traveling fellowships in Boston and Chicago. And then I finished off my training once it got training completed with a professorship in University of California at Sacramento, which was like the Craigavon of California. And that's early on in my journey, as I was a wee SHO. That was my first paper that I ever wrote. It was a case study about somebody who had esophageal cancer, and they got a metastasis to their odontoid peg in their neck. I remember that to this day because it was the first time that I'd ever done any proper research, and that it lit something up within me. I don't know if it got a bit of attention. I don't know what it was, but it was something needy was awoken. I went on to do my doctorate in DNA damage, and like bladder cancer, and means of assessing DNA damage and how to treat bladder cancer with chemosensitivity testing. And we got some publications out of that. But along the way, I sort of moved away from the cancer side of things and became interested in neurourology, which is, urology by virtue of folk with spinal or neurological disease. And that clinically, I found that fascinating. I started becoming interested in going to Musgrave Park Spinal Injuries Unit and doing work there. Again, we got a few publications out of that around transcutaneous neurostimulation for folk with abnormal bladders by virtue of neurological disease or otherwise. And as you can see from the testing that we did and the research that we did, we tended to focus on folk with false tans and filthy feet, and got very good results. So then towards the end of the training, as I mentioned, I did my fellowship at the University of California, Davis, which was an absolutely amazing place to work. A completely different culture. Money was no object. The amount of research going through was incredible. And we also worked in bottom right there is the Shriners Hospital, which is a Masonic corporation, whereby kids with either very specifically burns or spinal injuries or head injuries were admitted to. That's all they dealt with. And again, it was just, the quality of care, multidisciplinary clinics, it was just quite amazing. We did ward rounds with a member of one of the Shriners, who was like a mason who wore a fez on your ward round. And we had a pig on the ward round with us who had a wee Shriner's jacket on. It was surreal. At one stage I thought, whoa, has something kicked in here during a ward round, but it wasn't. It was just amazing. Again, we published a bit from there, got a good bit of clinical research done, and largely around reconstruction of using cadaveric fascia lata, so dead people's thigh, for treating stress incontinence and artificial sphincters for spinal injury patients. Always going really well, came back up my job. The problem with life is just that, it's life. And I became ill, and virtually everybody in this room will know what I mean by me being ill. Some of you who are here were integral to me getting back on my feet again, and one or two of you actually saved my life, and I thank you for that, and you know I do. It was horrendous. I moved from a situation where I had an unhealthy relationship with alcohol to becoming abusive of alcohol to morphing into alcohol dependency. And it flavoured every part of my life and it destroyed my life. And it brought me as close to death as you can get without dying. I was having epileptic seizures. I had an extradural hematoma. I was due to be rushed to the Royal to get my head opened. God knows what they would have found. At that time, and for the time thereafter, I lost everything. I lost my family, I lost my friends, I lost my home, and I had my money all taken off me because I went bankrupt. And I lost everything and I was impoverished, but strangely enriched because it gave me a new start. And that's all very well. But the problem is a lot of these tales you tell, the collateral damage is forgotten about. And my family suffered terribly from it. It's easy for me to talk about getting back on my feet and to be in the papers and stuff like that about it, but you could apologize to the end of your days and it wouldn't be enough. I wrote about some of the stuff at the end. That's a plug for the book. Go out and buy it. I need the money. How did I get back? I was reintroduced to Queen's, and Roy Spence played a very big part in this and get me back into life. I was delighted to be back working at Queen's. I started off working at the Medical Biology Centre, as it is now. I've worked in the anatomy department. And one thing led to another, and I ended up back in the medical school, etc. It got me into that building, which was great to be back into. Now it was all revamped, etc. It was great. And I got into a conversation online with an individual who turned out was three floors up from me. That was this wee beauty. So we got together and then we became a thing. We bought a cow and then we immediately published a book chapter. And we've done to publish a lot more since. She's now my boss and my wife. And I call her the warden and she calls me Hitler. We'll not go into that. So the next bit of the journey was where it started getting funky. I did a master's degree in clinical education, and it was the first time I'd heard about qualitative research. I didn't, all my research until then was being data-driven, DNA, numbers, all that type of stuff. And I got into qualitative research and I couldn't believe what this was because the fields were starting to come into this. And I thought, oh, you can research feelings. My God, that's quite remarkable. And I loved it because it got into this bit that I always had. There was two sides. There's the surgical side of your life, and then there was the artistic side of your life, and primarily music, but I also write a bit and things. I was always drawn to art, and the qualitative research worked for both. So the first qualitative research project we did after it got the master's degree was at the Department of Anatomy, and what we did was we got an old drawing of the heart and the great vessels, and we superimposed it with the help of Andrea Spencer, who's an amazing artist who I've worked, a lot of this work has been aided by her involvement. And we got these squares and superimposed them on top. Now the squares are made of aged linen, so they've got a sort of World War One battle dressing sort of look to them. We made incisions in the underlying sponge, which is sponge that we use to teach suturing. And along the incision lines, which marked out the great vessels and the coronary artery circulation, we closed the wounds, for want of a better word, with suture. So the folk who were, was a whole raft of people. Son John actually got involved and did a couple of stitches at one stage. They learned how to suture. They revised their anatomy and they worked together at creating a piece of art. And that's the final version of it there. That won a prize, the Irish Network of Medical Educators, and nobody was as surprised as I was. One of those tiles is mine, and I'll not say which one it is, but it's the one that looks absolutely magnificent. So that led to the next step, which I didn't see coming. Somebody from the BBC and somebody from the Ulster Museum contacted Queen's to say, there's a Da Vinci exhibit going on here. Do you know anybody who would be able to talk to this and give a public lecture? And strangely, I was approached. Now, what I should have said was, I'm sorry, I don't know anything about Da Vinci and I haven't a clue. But what came out of my mouth was, yeah, I'd be up for that, because somebody mentioned something about camera, and I thought, yeah, okay, and audience. So I ended up giving a public lecture about Da Vinci, and in the front row of the lecture was the guy who had written the definitive textbook about Leonardo da Vinci, and who I was freely copying from and using it as my own words. He was gracious enough just to give me a nod at the end, but I was absolutely mortified. The thing about the Da Vinci work, the more you looked at it, was his detail was accurate and representative, but his illustrations are imbued with life. There's more to it. When you look at the standard textbook illustrations as per Gray there, he was recognized as being the equal of any anatomist in history. And the degree of anatomical detail when compared to something from Netters is equivalent, but the degree of beauty, the representation of life and of art is entirely different of an order in Da Vinci's work. And to the trained, if you look at Henry Gray's illustrations and Frank Netter, who was regarded as being the medicine's Michelangelo, to the trained or untrained eye, there's an equivalent level of detail with Da Vinci's work compared to those guys. But Da Vinci has somehow captured the dynamics of the musculature, which is why the Da Vinci surgical system by Intuitive Medical was brought out to help perform complex surgery in a variety of areas, including urology, with minimally invasive keyhole approaches. Da Vinci was considered to have designed the first robot, which is why his unparalleled contribution to this area was recognized by the guys naming the Da Vinci robot after him. And you can see here that the surgeon working away at the console, directing the operation, which is actually happening. Very akin to Da Vinci's fetus within the gravid uterus. This is the design of a giant crossbow, which is currently in the Ambrosiana gallery in Milan. And you can see the similarities there as well. But again, it's the attention to detail. But you have to wonder, did it really get that far? So after that, the BBC then decided they were going to come over. And they came over, I think it was a Monday evening, and in the darkness of the Ulster Museum, I met with Will Gompertz, and we got a wee bit of footage done and a few photographs taken, and that was to appear on the news. And you can see there, I'm very pleased with myself. I'm very keen to show off with my watch, my waistcoat, and indeed my waistline. So I thought, I can't wait to show that to the kids. They'll all be really pleased, and I'll put that up in the WhatsApp group for the kids, and they'll be suitably wowed. And that's not quite the response that I got. Anyway, so less said about that, the better. Callum? That then led us on. I was now firmly in the groove for arts and health. So started doing a bit of very important work with Helen, who introduced me to Jenny Baxley Lee and a bunch of folk from Florida, the Center for Arts and Medicine there. We ended up writing a paper which turned out to be a white paper, which subsequently was used for government development within the States, which is something else. I don't know if I'd say that now, but it was quite, it was all around what do you call it? Is it medical humanities? Is it arts and health? Arts and health was the one we kind of settled on because it was suitably embracing. Helen, in the meantime, plodded away and formed the Renal Arts Group. She had never lets me get away with anything at all. So she formed her own group, which is looking at dialysis and the impact of art within that. And I'll come back to a lot because a lot of my journey from then onwards was involved with this group. And that got a lot of traction. There was a lot of stuff happened from that. We had the Create-a-thon event that was held over at the Ulster Museum. I'll come back to that in a minute. The Northern Ireland Festival of Social Science, Hope, Lost and Found, the Being Human Festival, which tied in very well with the Human Beings Being Human project, which by this stage was now starting to become a thing, and I'll expand on that in a minute. But if you look at Renal Arts Group, Renal RAG, Renal Arts Group, at one of the events that we had, this bunch of compadres formed. We played at one of these events it was down in the Sunflower, and there was poetry at it, there was soliloquies, there was monologues, there was a little bit of dance, there was some music, and then we played, and it was amazing. So this is the members. They're all here today, Lynn and Ali. We're basically the ancient poster boys of Ragboom, and part of the Renal Arts group. That's us playing in this very room, the cheek of it. One of the most poignant events in my journey was when, as part of that create-a-thon that I mentioned, Paul Murphy came and worked with us over at the Centre for Medical Education, and one of the patients that was involved in the Renal Arts group was William Johnson, who writes poetry and wrote plays. And William's now, his second kidney transplant is failing. A remarkable force of nature, as is Paul Murphy, who helped us to get his play that he'd written, what he wrote, into alignment with the School of Drama. And some of the actors there got involved, and we filmed and put this up as part of the Create-a-thon gig over at the Ulster Museum. My contribution towards it was that I wrote the music at the beginning and at the end for it. And at the end, we had a plan. Now, the central story to it was, and what played a big part in the intro to it, was Clive and Avril Waller, who are there. Their daughter Lindsay died in a quad accident, and her organs were harvested and used for transplantation. We dedicated this all to her, and there was a lot of footage at the closing credits of Lindsay throughout her life, her sadly short life, with my music playing. Helen and I were sitting at the back of the theatre, and Clive and Avril were there at the front, and all we could see was them breaking down at the end. We thought, oh no, what have we done? We've damaged these people. So I thought, right, we'll take it in the chin, and we got up and waited to see them afterwards. I was getting ready to sort of apologise to him that we might have made this a bit saccharine, a bit, overly sentimental, and we're sorry. And she thanked us profusely and said that this had allowed them to get closure. And it was one of the most gratifying moments of my life, both in terms of academia, life, music, everything. And it just made such a difference. And then you realise the power of this, the power of art within health. So we went on and continued to publish and do some more work. A lot of this is driven by Helen and her group. The research, the quality of the research coming out of the School of Nursing is just absolutely incredible. And a lot of it's been collaborative stuff with the School of Medicine, and also, but beyond doubt, the folk that I have encountered at this school are second to none. They really are remarkable academics and remarkable people. And I'll show you some of them afterwards. This is Sir William Osler, who's a Canadian physician who basically invented bedside teaching. And this is the first time there's a recognition of the humanity within a patient. And this type of thought, this type of approach aligned very well with the human beings being human. The project continued, but by now got a few folk on board. We've already mentioned the BBC were on board, both in terms of radio and TV. We formed the Transatlantic Arts, Humanities and Health Group with the Florida folk. Queens were integral to all of this. And I became a director at Arts Care, which I'll talk about later. So one of the first projects that we looked at was what was going on within the anatomy dissection room. Anatomy is very much a science, but it struck me that there was a humanistic aspect to it. I had a couple of students come up to me afterwards, particularly after they'd been doing difficult sections in the anatomy room, particularly around dissecting out the face or dissecting out the heart, and they were upset by it because they recognised that they were working at a human being. And there was one girl in particular said that as she was doing this horrifying dissection, that she kept thinking about what was the story from behind this individual who had kindly donated their body to science, as Lynn from the band's dad, Billy, did. And I worked on him too. We thought, why don't we look at that? We'll get these students when they're coming out and they're emotionally distraught. They've done an emotive dissection like that, and we'll ask them some questions. Ask them about what does being human mean? What does human being mean? And what does being a doctor mean? We asked them some other questions as well, and then we subjected the responses to a thematic analysis, very much qualitative research. Things that came out where consciousness became a thing, empathy became a thing, and knowledge, the actual requisite knowledge that you needed to obtain, were writ large. But particularly when we looked into the level of emotion in the room, so to speak, what we found is that the dissection was actually engendering blunting of folks' emotions. And I thought that can't be right. That can't be right. There were some changes affected in the anatomy dissection room thereafter, when a brief story and a name was assigned to each cadaver that had been donated. So there was a degree of humanism coming into a scientific act. We continued with that, and we expanded the work out to not just students, but postgraduates, academic staff, and acting healthcare professionals, medical and nursing, and pharmacy, the whole caboose. Every time I see that photograph, I see me standing in the background, the big bake on it, laugh, thinking to myself, I was actually getting paid to do this. This was in the Department of Anatomy when we used, we were always using chicken wire. I don't know what it was something we were sort of strangely drawn to this. It was a great substrate for art. And one of the anatomy lecturers subjected himself to a bit of torture throughout this, with the result that you end up with something that's vaguely Munchian, the scream. Had some members of staff formed a wire-based circle of Willis, which is the vascular structure at the brainstem. And then when we expanded out to different types of workshops, we found that there were some practitioners that were very adept at the eye of thread and should have been maybe followed a career in surgery. And they formed, just using pins and thread, very accurate representations of the brainstem and cerebellum. So it was becoming more and more apparent that there was this balance both between the right and the left side of the brain, which doesn't actually happen. It all works as an amalgam, but for description purposes, there's a right and a left side, and the right's meant to be arty and the left's meant to be the other way around. But there's also this balance between heart and brain, with emotions and thoughts being equally important. I just met one of my co-authors there outside. Sadly, he couldn't come in, Big Joe. You'll know him, Sean. This is another bit of work that we did within the dissection room in a summer studentship, and we had a whole bunch of students here involved. Some of them were even from astrophysics, and they came along and they created some basically very jarring artistic creations. And we used surgical material and we used articles from nature. So you've got, for example, in this one, this it was called Heart, I think was the name of it. You've got gypsum, which is used in plaster of Paris. You've got surgical tubing, anesthetic tubing. You've got surgical tape as well. And a sort of an anatomically correct yet emotive representation of the heart. And again, the coronary circulation in great vessels. This is flower lungs. The chicken wire made another appearance. There's willow hoops forming tracheal rings and bronchi. Within the chicken wire is a variety of substrates such as leaves, live nature, balloons, some surgical dressings, and a couple of bras, would you believe? Because, and I think this sort of sums the whole thing up. This is what we were doing. And a narrative appeared within this, that you were exploring anatomical and medical subjects, but you were bringing nature into it. This one is leg within a leg, and the individual who did this, her brother had lost his limb because he had an osteosarcoma and had to have an above knee amputation. And she got very adept at knowing what worked in the way of prosthetics, but she wove that into a narrative. So she developed her own version of what would possibly work as a prosthesis, using, again, chicken wire, but again, plaster of Paris and a variety of surgical tapes, etc., but wound in a narrative to that as well. So you got a story behind it, and it was really quite remarkable and powerful. Emotional representations of ECGs using chalk drawings, Good news for sinus rhythm and not so good news for ventricular tachycardias. So one of the areas that we looked at in teaching medicine is how do you teach it? One of the most effective ways of doing that is by simulation. And that's whereby you get folk into a simulated environment. You make it look like a hospital. You make it look like an operating theatre. You make it look like a ward. And you expose them to that with maybe simulated patients. And this happens a lot in the School of Medicine, School of Nursing. So you'll be, any folk that are from either of those schools will know what I'm talking about when I'm saying this. Simulation is probably the best way of retaining learning. It's shown time and time again that if you learn that way, it sticks with you. Whereas reading books and stuff like that, it just doesn't work. The old school stuff. And when you're looking at training doctors, technical skills, yeah, you can teach those at simulation. You can also teach non-technical skills, and I don't like calling it that, so I coined the phrase behavioral skills for that. But then there's other things. There's what I call higher order functions like empathy, professionalism, ethical issues, resilience. Can you teach those? Well, maybe. Healthcare is complex, and it's complex for a variety of reasons. A lot of it's the technology. There's a lot of stuff out there. There's a lot of kit. It interacts a lot of ways. A lot of drugs out there, a lot of dosages, a lot of stuff to remember. The communications complex within that arena. And then you introduce humans into it. So you get human healthcare workers, you get doctors, you get nurses, you get radiographers, you get pharmacists, you get the whole range. That makes it increasingly complex. And then just to completely blow it out of the water, you bring human patients into it, and that interaction between human healthcare professional and human patient. It's a wonder that it doesn't go terribly wrong a lot more often. So we started looking at healthcare human factors. And how do we address that? Well, I think you need to break it down, know what you're talking about. What do you mean when you say healthcare human factors? Well, in my view, there's numerous strands to it. There's things like the ergonomics, the gear that you work with, the environment you work with. There's technical skills. There's the behavioral skills that I've already mentioned. There's organizational issues like what regulatory bodies are there, what safety committees, etc., are available. What about the higher order functioning like empathy, resilience, professionalism? Thinking. Is thinking safe? We looked at that, and I'll come back to that in a second as well. Overall, our aim was to get folk in healthcare competent, but then to get them fluent in what they do. So move from competency to fluency, and then to perhaps maybe sometimes get them into a flow state. And a flow state's Mikhail Csikszentmihalyi is the guy who's mainly written about this. And it's where you're completely immersed in something, you're lost in it. You've got positive hyper focus, you've got an energized mood to it. They say that it happens to surgeons sometimes, maybe, rarely. I know that it happens in, for example, musical performance where you're completely lost in it and time can go by. That's when you know you've got it. Can you get into a flow state in medicine, healthcare? Yeah, I think you can. Csikszentmihalyi again said that flow states are central to the provision of high quality healthcare. So that's a good thing to aim for. If you can aim for that, the safety and all that will come with it. The safety is a low hanging fruit. You're setting the bar relatively low. If you're just going to look at a patient safety agenda, I think you need to look at quality and then drop down. The safety will come with it. The School of Drama, I've already mentioned about doing that film with Avril and Clive's daughter, Lindsay. This was the Health Theatre project where we got drama students to come over and help us out with the simulations. Again, Paul Murphy was central to all of this. Paul, anybody who knows him, he's just a complete force of nature. If he's not a prof, he should be. Instead of he's just like me. So what we did was we had interdisciplinary education and action. We called it, we won a prize for this. They give us a prize for nothing nowadays. We got simulated scenarios for folk that are acutely ill by virtue of a variety of things. And instead of having just ordinary simulated patients who tend to be ex-patients, we got drama students in. And what they did was they got themselves immersed in Stanislavski method acting. So they became over the course of a week or two by studying. They became the patient. So they were not only very realistic, but they also acted as an advocate. Then when we got everybody together and got them into the simulated environment, it was very interesting to watch what happened, because what we were hoping to do was to get them to hit the sweet spot where you're performing just really well, but also to keep yourself safe, self-care, and be aware that when you're getting overly stressed. At first, when students came in, and we got real patients in the background there to score both the students and the drama students and the medical students and the medical staff, postgraduates, all that, just to get a complete global picture of what was going on. The drama students were blown away. They thought, oh, this looks just like a real hospital. This is amazing. They were sort of taken aback at first. The medical students were all running around, the senior medical students thinking we're medical students, we're class, so we're better than everybody else, blah, 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 blah. That then rapidly reversed once we got into the simulated scenarios, because the drama students had our guys on the ropes in no time at all. They had them stressed out and functioning really well, which I'll show you in a second. Then we had a debrief afterwards. The feedback, which I'll not dwell on, it was brilliant. The drama students loved it. The medical students loved it. The actual patients couldn't believe what was happening in front of their eyes. But then what happened, we introduced a wee bit of quantitative, qualitative research to it, and we looked at their amount of learning in human factors and in patient safety. And they all agreed that both groups were found that they were improved, but certainly when we did it in an interdisciplinary setting. And then when we looked at the folk that had been exposed to the drama, if it was medical students only, at the morning session in blue, they were performing quite well on their scores, their clinical performance scores, and they did better in the afternoon because they were improved. But when you threw drama into the mix, you can see the massive difference, and that was highly statistically significant. Quite amazing what you can perform. So getting back to the healthcare human factors, you've seen this fellow down the stairs. That's Galileo by Pio Fedi. Cognition was the other area we wanted to look at, because if you're going to improve people's thinking, you can't just throw knowledge at it and they start thinking. Can you change the way they think? You're talking about forming new neural pathways, getting them to practice it so that it improves it. Remembering that practice makes permanent. Is that right, Wesley? And you have to have some type of measurable outcomes. We wondered if you could introduce the art side of things again with this work. And we did this across the board for postgraduates, undergraduates, and healthcare professionals. We worked with Andrea Spencer, who works with glass. She's a glass sculptor and a remarkable human being, an ex-patient herself. And when we showed this glass work to vascular surgeons, they thought that there was lots of little aneurysms. It's not, it's kelp. Showed this to, if you show that to a nephrologist, they think it's kidney. It's not, it's leaf. Then we introduced funny things, odd stuff that would jar their mind about perception. Those two lines are the same length, believe it or not. There isn't a triangle in the middle of that. It just looks like there is. Shepherd's tables, those tables are exactly the same shape and dimensions. I swear to God, they really are. And that throws people completely. Pulmonologists thought that was lung. It's not. It's leaf. And then we got them to involve some of the, you've already seen one of those bits of work, but we got them to do various types of work around artful creation. Put the two things together, do workshops like that, throw some knowledge in, then get them to analyze a blood gas. What happens? Well, what we found was that the study group who had been exposed to the art and to the cognitive testing performed better. But when we threw a wee sneaky question in there that would throw you a bit, the patient was actually quite sick, and if you didn't pay attention, and you could miss that. So the correct illness classification was much, much higher in the group that were exposed to the artwork and the cognitive work. So there's this talk that, you need less emotion and more reason to have thinking to be of high quality. It's not that. You need both. Because if you look at a map reading is a good example of that. If you use your emotional side of your brain just to look at the map, you'll get the overall feel for it. You get the vibe, you get all the stuff you need, but then you need the extra detail. You need the right brain thinking, for want of a better word, to try and see the details. So you've got the full picture. So again, we're back to this thing, trying to get the balance between the right and left side of the brain and between the heart and the brain. So then when you're thinking of the brain, you have to think about self-care as well. What can we do with art in that area? What can we do with other non-medical things in that area? Can we make thinking a bit more reasonable and a bit hard, a bit less difficult and challenging? Well, you can introduce mindfulness, and I've meditated for years since I got into recovery. I taught Helen how to meditate, and then she became, as always, has to go one better, and became a mindfulness teacher. So she has done remarkable work, and we did some work together about this with students. The picture there of the brain on the, if I can get this bloody thing to work, hold on. The brain there, that's what happens. That's the parts of the brain that light up when your mind starts to wander. You become aware of it when the insula kicks in, and then meditation allows this part of your brain, your prefrontal cortex, to start working, and it keeps it sustained there. So that's anatomically what happens, neuroanatomically. And what it's doing is it's moving your erroneous thought processes away from the emotional center, which is your limbic system, out into the cortex. We found that we could improve people's mindfulness scores by teaching them meditation, and that's undergraduate, postgraduate, and interprofessional. But when we looked at resilience scores, they were significantly increased as well. So now we're starting to see where it all fits in. It's all about life. It's all about love. What about those higher order functions I was talking about? Empathy, conscientiousness, and resilience. How the hell do you teach that? That's one definition of empathy. There's another one. Can you teach that? And if you are going to teach it, how do you teach it? Because if you get all that right, the rest follows. And that's where arts care came into it. This is just one example. This is a summer studentship, like a sort of mini elective. I ran the electives for a long time. And that's Andrea Spencer there that I mentioned, the glass artist. That's her giving it a bit of art there, big time. Bit of drum therapy. We had students who were involved, and they worked with largely patients who were undergoing rehabilitation. So they worked with Down syndrome patients, patients with limited mobility. Interpretative dance, artful constructs with reflective journals, and the creation of remarkable pieces of work using felt. And if you look there, you can see words starting to emerge. There's respect, there's communication, empathy. And it was powerful to watch these people, particularly when they were working with students. I remember standing watching a dance with some Down student patients with this group of guys in the foyer of the city hospital and being brought to tears. I was a sobbing mess. This was just a joy to watch. You saw people interacting well together. They were getting healthcare, and they were getting healthcare at the higher level of functioning. And we talk about, team working. Well, I think arts care have shown that if you're going to build a team, maybe that's the best way to go about doing it. And it led us on to developing Schwartz rounds. Billy, Joan, and Marion are here, and they'll know about what I'm talking about. Schwartz rounds, that's basically where you get everybody that works in a hospital or in healthcare to come in and talk about the emotional aspect of their job. And it's open to everybody. A lot of it's based around balance psychology, and that's one of the areas that I'm interested in because I work for the Institute of Sexual Medicine, where Helen and I were over the weekend giving a wee talk. Went terribly well in Birmingham. That all works very well. It's all about talking. It's all about having emotions writ large, and it's all about being aware of that side, that what was previously seen as the soft side. Lastly, there is a therapeutic dimension to this type of work, and I could go on and on about the renal care. Helen would be better placed for doing that. But when you look at breast cancer, there's a little bit of work that I did with the Personal Link group. And they basically work in folk who have had mastectomies or partial mastectomies for breast cancer. And they've developed bespoke tattoos to enhance, partially cover up, but also to express what goes on when you have a mastectomy scar. Some of you will know the next patient is Molly, who's more than happy to have her picture taken. Her family, and she underwent bilateral mastectomy and implants, and she and her family designed a tattoo based around a water lily. So she was able to enhance her surgical scar, but also have a degree of narrative thrown into there as well. I've mentioned the group in Florida. Far right there is Jenny Baxley Lee, who's a dancer primarily, but an unbelievable academic. And one of the members of that group died from metastatic ovarian cancer, and the rest went on to form journals interpreting the journey, and also some interpretive dance was designed that allowed that all to make sense to all of them and to the bigger public. What we're talking about here is just breaking down silos. There's not a school of medicine, a school of pharmacy, and a school of nursing. It's healthcare. There's not a separate school of drama and a school of music. It's all to do with breaking down silos. We all work together, and it's all about the journey. If there's one thing I've learned, it's all about the journey and who comes along with you on that journey. And most of you are all here. Getting the right and the left side of the brain working together, yeah. But always remembering that art is where art is one of the things that got me out of the doldrums when I was sick and I was trying to get back on my feet. Art, music, and writing were the things that did that for me. That's the book. Buy it because it's on Amazon and I need the money. This is the last slide. You'll be glad to hear. A palpable sigh of relief. Baldy has finally come to the end of his ramblings. This is an artwork commissioned by the warden. It's based on a doodle that I did at a workshop. This has followed me around a few of my homes, and it has a few bits to it. Helen went and got a guy called John Rubery, who's a musician, who has followed me around and actually done caricatures of various musicians in play, including myself. The central bit here is a book which represents the academia. The treble clef there represents the music. The big heart's my family. That's love. And then there's a wee bit thrown in there with a bit of blood, because I'm a surgeon, but I'm not a very good surgeon. Thank you all very much for listening. There was to be some music there, but nah, it's not going to play. So you're spared that. Thank you very much.
Well, ladies and gentlemen, it is my great privilege to offer a few closing reflections on what has been an inspiring, thought-provoking, open, honest, and truly inspirational inaugural lecture by Professor Ian Walsh. This evening, we have been invited to explore the profound connection between art, humanity, and healthcare. And what a compelling invitation it has been. Professor Walsh has eloquently reminded us that healthcare is not merely a science or a service, but a deeply human experience, one that touches the full spectrum of emotion, vulnerability, resilience, and connection, and also reminded us the importance of breaking down silos and how important that is for healthcare. By championing the integration of arts and humanities into clinical practice, Professor Walsh has shown us how we might reimagine care, not just as a medical act, but as a shared human endeavour, where emotion and reason come together. One in which creativity, empathy, and expression are not additions, but essential. So I'm opening us up for questions. I'm sure there's many from the audience. And I'm happy to start by one with myself, if that's okay. So from your experience, what really helps people to engage in that art-inspired learning that pushes them slightly out of their comfort zone? You did that lovely graph with actually, good stress. What are the key things that get some of our medics or healthcare professionals to really tiptoe into that stressful area?
Tiptoe is right. What we had found was that you need to sneak up on some of these people and say to them, do you want to come along to this workshop? Usually if you offer them sandwiches, that helps. I was amazed how many of the hard and fast surgical trainees engaged with this. They said that it opened up a side of them that they had either not been aware existed or that they'd given up on. I hate to hear undergraduates saying, oh, I gave up playing the violin because I was doing whatever. The shoulders of giants that I've stood upon, and the surgeons and the physicians and the healthcare professionals that have really impressed me have all had an artistic bent to their gig. And I think we need to start recognizing that and embracing it. And plus the fact a lot of them said that they found it very therapeutic from a stress point of view. And that was not just healthcare professionals, but also academic admin staff are saying it was great to be involved in that. You get a real team working together, creating something. It's amazing.
Thank you. Any other questions from the room? Don't be shy now.
Oh, they're not shy. Oh no.
They're quiet tonight, though. Yes.
It's more an observation. Firstly, congratulations. Absolutely fascinating insight. Yeah, again, there's another bit about you I didn't know about. So
Thanks, bro.
I thought I knew it all. My observation is that it's great to see in the branches of medicine, but the arts in medicine seems to be, I'm incorrectly going to say relegated, but assigned to mental health and recovery.
Yeah.
And it's good to see that you're pushing forward to make it permeate mainstream medicine over physical medicine or non-medical interventions. And I think it's a really good thing.
Yeah, it's there everywhere, you know. I mean, I've seen it at various levels. When I was working in California, and there was an orthopedic surgeon, he operated on kids, doing very intricate spinal surgery, a huge big guy. And he had death metal playing in his theatre. At the time, he could only concentrate with that playing. I was playing a deafening volume. There's another cardiac surgeon that some of you will know who used to play Neil Diamond all the time when we were playing. Same song, time over time. These operations take 8 hours. So there's that side of it as well. But there's this sort of thing you can't do both. You can. There's somewhere for the art to fit. And in so doing, it will improve your healthcare, the provision thereof. And it's not just for rehabilitation and mental health. It's the whole kibbutz.
Yeah, the placebo effect is massive.
Mhm.
Very fascinating. So do you think the placebo effect is that ability of the doctor to create a placebo effect is artistic? Is that something you should explore?
I think so. I think there is that, but I think if you do it well, you outstrip the placebo effect, which is typically just sitting around 30%. But I think if you do a lot more, especially for the type of patients you're dealing with, the chronically ill patients.
So this placebo effect, the
yeah, and you can do that. And the good doctors are the ones do it. Yeah, and how much progress you can make with somebody just by listening to them. You know, if you look at the guys who do the good anaesthetists who look after chronic pain, if you speak to them, they'll say, I spend a bit of time and listen to the patients. Like getting on like a doctor, maybe, you know.
Yeah, right at the back.
Very much so. Very much so. And I think that stems back to right from the way it's taught at undergraduate level. You're going to teach healthcare. The key word there is care. It's not the health side of it. And I think we've lost that. And I think that this division where we had, you know, there was nursing and there was medical, I think we lost that somewhere along the way. Whereas, you know, you were dealing with, if I was dealing with a difficult patient, before I get sick, if the patient was upset or there's a problem, I would have got one of the nurses in to act as an advocate and to soothe the patient. Why couldn't I do it myself? So we have lost touch with that. And I think as the technology gets better and better, we do run the risk of that going further away. So we need to bring this stuff with us. This stuff works, it really works. I can swear by it. Sorry, there was another one.
You've opened the floodgates here.
I know.
Just want to one thing that came across me in your talk, and something that's reflecting in your own behaviour towards me in particular. My own experience of it is academic generosity, the decision not to hold your knowledge into yourself and just to share your connections, share your insights. I think that's underrated and strangely neglected in academic life. At your inspiration, I'd like to start practicing it myself. Share stuff around. So,
Totally. I mean, it's
share good ideas are always better when they're shared, and I have benefited immensely from a good idea and a contact Paul Murphy you shared with me about 6 years ago. Maybe?
yeah, that's right. Yeah. It's also amplified by that sharing, you know, so you can even look upon it as being a selfish act. If you engage and work with somebody, you'll get stuff that will come out that you would never have even thought of. You know, Sean does a mean Tom Waits, by the way. I backed him up with guitar one time. Yeah.
Right there.
I've seen it. The only reason why I'm so passionate about it is because I've seen it working so well, and it feeds back. Every aspect of every one of those projects that I was involved in hit me somewhere emotionally, and I knew this is really important. This stuff. When the time of the drama students were over in simulation center, I remember saying to Paul Murphy, I said, hairs are standing up at the back of my neck. That's the only place that there is hair above my neck. And you know, that time when we showed the video with the music playing and Avril and Clive were broken down, it was just like, oh my God, this is where it's at. This is why you do healthcare.
Thank you very much. So, Ian, on behalf of everybody here, can I thank you for your scholarship, your leadership, and your humanity. We're incredibly proud to have you as part of our academic community here at Queen's. Your work enriches not only our university, but the lives of everybody that you touch. Your care and compassion as a healthcare professional, as you've heard here tonight, you inspire people and your generosity shows no bounds. So thank you to everybody who's joined us this evening, and a great big thank you to Ian. Thank you very much. Please do continue the conversations and let us all leave here reminded of the power of the arts to heal, to connect, and above all, to make us all more fully human. Thank you all so much.